Last month, House leaders began drafting new reforms to Medicare Part D. That is the prescription drug benefit for Medicare beneficiaries. That move is part of a push to cap what people have to pay out of pocket for their medications. Here to elaborate on these changes is Senior Health Policy Advisor Matt Kazan. He spent over a decade working with Senators Max Baucus and Ron Wyden on health care policy. Great to have you, sir.
Thank you. Glad to be here.
So, first, take us through what is the kind of current state of Medicare Part D? How much are seniors having to spend out of pocket for their drugs?
So it varies tremendously based on how much drugs, what type of drugs people pay. About $30 a month per premium, and cost sharing can vary significantly from $20-30 a month all the way up to $2,500, $3,000 once they hit the catastrophic phase of the benefit.
Wow! And so, what are some of the ideas out there for making that drug coverage more affordable for seniors under Medicare Part D?
Yeah, there seems to be kind of three main ideas that are getting battered around. Number one, allow Medicare to directly negotiate with drug manufacturers. Number two, impose an out-of-pocket cap on Medicare Part D where it does not have one today. And three, change the financing of the program to make health plans and possibly drug manufacturers pay more for the program.
One thing that gets floated a lot, as you said, is that idea of negotiating directly. I mean, why isn't that being done now?
So when the law was created, Congress explicitly prohibited Medicare to directly negotiate with drug manufacturers, and it's been very controversial ever since. Also, the Congressional Budget Office, CBO, has said that providing that authority without additional policies doesn't save the government a whole lot of money and won't do a lot to bring down drug prices. So I think those are some of the reasons why Congress hasn't been able to make that change.
So of those approaches that you talked about, what do you think would be most effective? Should you just cap the out-of-pocket expenses off the top, or do you think that we need a combination of efforts to try to get the cost down for seniors?
Yeah, I mean, that's part of the big debate. I mean, clearly an out-of-pocket cap would help those beneficiaries who spend a lot every year on prescription drugs, and other insurance products have an out-of-pocket cap. So that would be one way to at least shield the beneficiaries from high costs. But a lot of folks in Congress have also talked about kind of the financing mechanisms and what, if any, incentives those play, and should those be changed to reward kind of lower cost drugs.
I've even seen the idea floated of the government essentially manufacturing some of the generic drugs to compete with the private market. Is that something that has a serious traction as an idea?
I suspect that would be very controversial and hard to get bipartisan compromise. And of course, anything this year would have to be done on a bipartisan basis, given the Senate and the House in being in split parties.
So I know you're a policy expert, but I'm sure you're well aware of the political challenges here as well. I mean, when we talk to lawmakers, the two areas that they tend to bring up as places where maybe something could happen are on infrastructure. It's not looking so good these days anymore. And on drug prices. Do you think there's any realistic hope that we could actually see some movement on prescription drug prices in general, but specifically with regards to Medicare Part D?
Yes, I think on both of those drugs and specifically Part D, congressional committees are working together, and they're working together on a bipartisan basis, both in the House and the Senate, specifically on Part D changes. And so as you see the committees work and put out a product, that advances the ball. Obviously, the administration and the president are talking about these issues and are on board. And so Congress has to do a major budget deal in the fall. And you could see a scenario where the committees produce a product and that is debated as part of this fall budget deal.
What is the Trump administration advocating for?
So in the president's budget, there were similar changes to Part D that we've talked about before, an out-of-pocket cap, changing the financing and Part D's reinsurance to increase what health insurance plans pay as part of Part D. So some of the similar things that Congress is talking about now.
So what's your assessment of the Trump administration's recent decision to remove the safe harbor protection for drug rebates in Medicare Part D? How do you think that's going to play out?
Right. It's a very significant change to the program and how it's financed and how beneficiaries receive their drugs. It's obviously only in a proposed state right now. Proposed to start in 2020. Those premiums for that plan are getting set right now, and people are wondering if it will be finalized in time to make it effective for 2020. And
so what will that look like for seniors? Just like on a super pragmatic basis.
Sure.
Yeah.
So for seniors who take expensive drugs that receive or have large rebates associated with those drugs, they will see lower cost sharing at the pharmacy counter. For beneficiaries who do not take those drugs, they will see an increase in premiums.
Gotcha. All right, so who are the point people on the Hill? Who should we be watching as we look to see whether any progress is actually made?
Certainly the committee chair and ranking members of all the committees that are involved in the Senate Finance Committee, House Ways and Means, House Energy and Commerce. They'll be putting out draft legislation or moving the legislation through the Congress. And then certainly leadership, and then Secretary Azar and his team, and how they will work with the Hill to negotiate a final package.
Great. Very interesting stuff. Thank you so much, Matt, for your expertise. We appreciate it.
Thank you.
We're going to toss it over to my colleague Sagar for more.
The search for innovation in Medicare is ongoing. Dr. Mark Fendrick, who leads the VBID Center at the University of Michigan, is a pioneer in the space. He's coined the term value-based insurance design, which aims to reduce Medicare costs and boost quality of care for Medicare recipients. He joins us now via Skype to delve into his model VBID. Doctor, thank you so much for joining me.
Great to be here. Thank you for having me.
So, Doctor, there are a lot of leading voices in the industry that are talking about reforming healthcare to make it more value-based. What does that mean exactly for a general audience, and how does that impact the delivery and the quality of the care?
Well, at the Center for Value-Based Insurance Design, we've been focusing on the out-of-pocket costs for Medicare beneficiaries, which have been going up dramatically over the years. Some people think that even though you have a Medicare card, that means you get 100% coverage of the care you need. So as more and more Medicare beneficiaries have had to pay more, they've actually been buying less of the services they shouldn't get, which is why we would put cost sharing in place. But they also don't buy the services that we beg them to do. So we've been trying to put forth a new idea that instead of setting cost sharing in a one-size-fits-all way, that patients pay the same amount for every doctor visit, diagnostic test, or drug, value-based insurance design sets cost sharing to be low on those services that are most important the Medicare beneficiaries' health. And our hope is that if people pay less, they'll actually do the things that'll make them healthier more often.
Yeah, that's very interesting. So how can value-based healthcare principles actually improve Medicare as a program overall?
Well, most people believe, and not just Republicans and Democrats, but all stakeholders, that there's more than enough money in the Medicare system. The problem is we're just spending it in the wrong places for reasons that some of them are explained and others aren't. Our motivation is that Medicare expenditures should improve individual and population health for Medicare beneficiaries, and that the benefit design should steer those beneficiaries to get the care that's going to make them healthier, and hopefully avoid the care that may actually harm them. We hope then to align this benefit design change with the very exciting innovation that's going on in the payment reform place, such that the dream of mine is that Medicare beneficiaries will be able to get services where it's easy for their clinicians to order them and affordable and accessible for those Medicare beneficiaries to actually receive them. And in those situations, it is our hope that individuals and populations will be healthier.
Well, that is the direct hope, is that you want to improve the costs and you want to improve the services. But what are some of the forces and the impediments right now that are standing in the way of a value-based innovation for Medicare?
A lot more attention is being paid to how much we're spending as opposed to how well we're spending in Medicare. Because there's enough money in the system, as we apply levers for clinicians like myself to provide more services for which evidence is strong to improve health, and hopefully do less of those services that do not make Medicare beneficiaries healthier, that we could align these innovative payment reform systems that go from volume to value to make sure that when a clinician says to a patient that something is really valuable in terms of their health, that their benefit design will make it easy, not hard for them to get them. Unfortunately, cost-related non-adherence, that being Medicare beneficiaries not getting the care they need because they don't have the money to buy it, is a real and growing problem. And value-based insurance design, along with value-based payment, is one of those ideas that will hopefully reduce cost-related non-adherence, and patients will be able to get the evidence-based care they desire.
Right. It's all about driving the cost down for paying those services. So how are the value-based programs already impacting inside Medicare? Are they aimed at the end stage, like renal disease and nursing-skilled facilities?
Well, like the famous bank robber Willie Sutton, who robbed banks because of that's where the money was, we have focused our efforts on value-based insurance design in those clinical areas where lots of money is being spent in the Medicare program. That's common chronic diseases like cardiovascular disease, cancer, pulmonary disease, mental health, HIV, et cetera. So what we are trying to do in the value-based insurance design model test is to encourage Medicare Advantage plans to identify services and providers that provide high-value, efficient services to their member beneficiaries. And in those situations, for the first time ever, the Medicare Advantage plans are allowed to lower consumer cost sharing for specific providers and services. So this is the first time in the 50-plus years of Medicare where plans can actually focus cost sharing on specific individuals with chosen chronic diseases.
Got it. In 2019, one value-based program that is being implemented is actually the alternative payment model. So how could that CMS experiment result in major improvement for Medicare overall?
So as we've been dealing with since the advent of Medicare, clinicians have been paid fee for service, that for everything they do, they get paid. We realize that there's a bit of a lack of incentive then to focus on those services that are specifically found to be beneficial to Medicare beneficiaries. So most of the alternative payment models move from this volume-based reimbursement to value-based reimbursement. So for instance, as a general internist, I am encouraged to get my patients with diabetes to the eye doctor. What value-based insurance design tries to do is align the consumer with these alternative payment models and make it inexpensive and easy for that patient to go to the eye doctor as opposed to it being hard. It is our hope then, with the alignment of both alternative payment models and insurance design, that the triple aims of Medicare, improving patient experience, higher quality, and lower cost, can actually be achieved.
So, Doctor, what are some of the value-based programs and experiments that Medicare still needs to put in and implement?
Well, we're very fortunate that a few years ago, CMMI started the value-based insurance design model test in 7 states with a handful of chronic conditions. Over the years, the value-based insurance design model test is one of the very, very few that was started under a Democratic administration that was actually expanded under a Republican administration. So now Medicare Advantage plans can implement value-based insurance design principles, that being lowering cost sharing for high-value services and providers in all 50 states. Moreover, Secretary Azar and Administrator Verma have been talking about the expansion of the value-based insurance design model as VBID 2.0. And this is an expansion of the original few states and few conditions to allow the expansion of cost sharing to much broader sets of clinical services, for end-of-life discussions, for telemedicine, and other areas that we all believe CMS should innovate to improve patient-centered outcomes and hopefully get cost growth under control.
Very interesting. Thank you so much, Doctor. We really appreciate you joining us.
My pleasure, Sagar. Thanks for having me.
The future of Medicare continues tomorrow with a spotlight on how the SCAN Health Plan is finding new ways for patients to receive care from their own homes. We'll have more rising for you after this.